So sorry, finally, Dr. Hedy will talk about the Cairo University IBD multidisciplinary team success story. Sorry, Doctor.
Thank you so much, Professor Mohammed Hamid, for this lovely introduction. Thank you, Mr. Chairman, dear professors and colleagues. Today, we will talk in brief about the multidisciplinary team approach adopted in our IBD care in a case-based approach. The prevalence of inflammatory bowel disease, including Crohn's disease and ulcerative colitis, has increased over 2 to 3 generations in high-income countries. However, it has only increased in one generation over the past 25 years in much of the newly industrialized and developing world, including countries such as Egypt. In developing countries, inflammatory bowel disease has a severe phenotype, which has the same complications, morbidity, and mortality as in established patient populations in high-income countries. With recent advances in the IBD treatment, a one-size-fits-all plan is no longer an option. Our clinic offers personalized care for IBD patients, whether ambulatory or hospitalized if needed, which translates into better patient outcomes. On the patient's first visit, a full history and examination are taken. Routine labs and endoscopy is ordered, and accordingly, the disease severity is then assessed. The next step is to take the clinical decision in a multidisciplinary team approach, and accordingly, a treatment plan is set. This goes hand in hand with a proper patient counseling, and subsequently, the patient's follow-up visits are then scheduled for close patient monitoring. This here is the electronic sheet form we use for IBD patients presenting to our MDT. It includes sections about the patient's personal data and clinical history and surgical history and clinical examination. It also has sections for results of laboratory, radiological, and endoscopic evaluation. And finally, we document the MDT decision and the patient's medications. On subsequent follow-up visits, the patient's new clinical data and laboratory, radiological, and endoscopic new findings are then recorded. Owing to the complex nature of the disease, we endorse a multidisciplinary approach. Our team is composed of gastroenterologists, surgeons, radiologists, rheumatologists, and named pathologists. Together with their combined efforts and expertise, we ensure the provision of the best suited evidence-based care for our patients. We hereby present an unusual cause of skin rash in a patient with Crohn's disease. A 21-year-old male patient who was previously diagnosed as intestinal Crohn's disease presented to our clinic. His condition started 3 years ago in the form of pain in the right iliac region associated with diarrhea alternating with constipation together with anorexia. The patient was prescribed conventional therapy in the form of steroids and azathioprine, but without improvement in his condition. He was referred to our MDT clinic on November 2019 for the possibility of biological therapy. The patient's history was unremarkable apart from abdominal pain and altered bowel habits. On general examination, he appeared underweight but was fully conscious and vitally stable, and he had a BMI of 19.5 kilograms per meter square. His abdominal examination revealed only slight right iliac tenderness, and there were no signs of extraintestinal manifestations. The patient's laboratory investigations were all unremarkable, apart from the high fecal calprotectin of 732 micrograms per gram. On colonoscopic examination, the whole cecum appeared edematous with ulcerated mucosa, and the rest of the colon appeared normal. Multiple colonoscopic cecal biopsies were taken for histopathological examination, and they revealed cecal colitis with active erosions with the possibility of Crohn's disease. CT enterography was done, and it revealed only limited small bowel ileal involvement with no complicated fistulous tracts or adhesions. The pre-biological therapy workup was done, which included the tuberculin skin test, which was negative, and a virology profile, including hepatitis C antibody, HIV antibody, hepatitis B surface antigen, and hepatitis B core total, which were all negative. The patient was started on infliximab infusion at a rate of 5 mg per kg body weight at 0.26, which was followed by a maintenance dose every 8 weeks. The patient achieved a clinical remission where his abdominal pain and alternating diarrhea and constipation dramatically improved after the second dose. Unfortunately, however, after the 5th dose of infliximab infusion on May 2020, the patient started to notice an erythematous skin rash that appeared as small vesicles, gradually desquamating, leaving shiny scales mainly over the palms and the soles. Looking at the cutaneous manifestations of Crohn's disease, they can be broadly classified into 4 well-accepted categories. The first group is the group of specific lesions which share the same histopathological findings consistent with Crohn's disease on biopsy. The second group is the group of reactive lesions, which are inflammatory lesions that do not share the same histopathological findings with Crohn's disease. And the third group is the group of associated lesions that are likely to develop due to shared HLA gene types or secondary to chronic inflammatory response. Lastly, we have a group of secondary cutaneous manifestations which occur either due to complications of inflammatory bowel disease itself or as adverse effects of IBD treatments. Looking at the first group, a group of specific cutaneous manifestations sharing the same histopathological features as the underlying IBD, they can be further subcategorized into orofacial aphthous stomatitis, which typically appears as or presents as round to oval shaped ulcers on the buccal mucosa and the lips. Typically taking around 2 to 4 weeks to heal, and they may frequently scar depending on their size. Next in this group is the perianal fissures and fistulae. The perianal fissures are typically painless, and they are usually located posteriorly, and the perianal fistulae can be either internal or intercutaneous, and they can destroy the anal sphincter. Last in this group is the metastatic Crohn's disease, which is a rare occurrence, and it usually presents as subcutaneous nodules or non-healing ulcers, and it can be further classified according to its location, either into genital, which is more common in children, or non-genital, which is more common in adults with a female predilection, and it commonly involves the lower extremities, the abdomen, and the trunk. The second group is the group of reactive cutaneous manifestations with immunological mechanisms that are related to the underlying IBD. These include erythema nodosum, which presents typically as painful tender warm nodules on the lower extremities, and pyoderma gangrenosum, which presents typically as non-infectious nodules developing into deep and painful ulcers, usually around peristomal regions or lower extremities. Third in this group is Sweet syndrome, which typically presents as tender nodules and papules over the upper limbs, face, and neck that is usually associated with fever and peripheral neutrophilia. Then we have the bowel-associated dermatosis arthritis syndrome. This typically presents as erythematous macules developing into painful papules and pustules over the upper chest, arms, legs, and it usually develops over the course of 1 to 2 days, resolving over 1 to 2 weeks. Then we have the PDV and PSV and PPV, which are collectively a group of pustules in the skin folds or hyperplastic folds in the buccal and the labial mucosa, progressing into shallow ulcers. Last in this group, we have the leukocytoclastic vasculitis, which ranges from palpable purpura to necrotic ulcers. Here on the left, we have a typical case of erythema nodosum on the lower extremities. On the upper right corner, we have 2 pictures of pyoderma gangrenosum. In the middle, we have a picture of a typical Sweet syndrome case. And lastly, on the lower right corner, we have a bowel-associated dermatosis arthritis syndrome case. The third group is the group of cutaneous disorders associated with IBD, and this includes typical or classic psoriasis, secondary amyloidosis, vitiligo, acquired epidermolysis bullosa. Lastly, the fourth and the final group is the group of secondary cutaneous manifestations that occur either due to complications of the inflammatory bowel disease itself or as adverse effects of the treatments used. These include cutaneous manifestations of zinc deficiency, iron deficiency anemia, essential fatty acid deficiency, and lesions developing due to corticosteroid usage, such as steroid-induced acne, or finally, anti-TNF agents, which may be a cause for a paradoxical anti-TNF agent-induced psoriasis. Back to our patient, we consulted the senior rheumatologist in our MDT group, and a differential diagnosis of small vessel vasculitis versus a drug-induced side effect was made. The patient's laboratory investigations were repeated, and they were all unremarkable. The immunoglobulin G and A and the complement 3 and 4 levels were within the normal range. The immunological panel was done, including rheumatoid factor, PNC ANCA, and anti-nuclear antibody, and they were all unrevealing. A further dermatological consultation spot diagnosed the lesion as a rare case of paradoxical psoriasis due to anti-TNF agent infliximab. A skin biopsy was then performed and it confirmed the diagnosis of psoriasis vulgaris. Historically, anti-TNF-induced psoriasis was considered as a rare occurrence, but it's now more commonly encountered given the high popularity of anti-TNF agents, including infliximab. Paradoxically, anti-TNF agents may induce or worsen psoriatic skin lesions in about 0.6 to 5.3% of the patients, with Crohn's disease and rheumatoid arthritis being the most common underlying disorders in this group of patients. The mechanism of TNF inhibitor-induced psoriasis remains unclear. Several theories have been proposed, which include the increase in type 1 interferon and an increased number of interferon gamma secreting T helper 1 and interleukin 17, interleukin 22 secreting T helper 17 cells. This is a proposed algorithmic approach to the management of anti-TNF-induced psoriasiform skin eruptions. First, in case of mild skin eruption with a controlled underlying disease, a treat-through strategy is usually adopted. This means that we should continue the culprit anti-TNF agent at hand and treat the psoriasis symptoms using either topical steroids, UV therapy, or methotrexate or cyclosporin. Then, in case of a mild skin eruption with uncontrolled underlying disease, or in case of a moderate to severe skin eruption with a controlled underlying disease, the management would be to switch to a different anti-TNF agent and to treat the psoriasis symptoms similarly as previously. Finally, in case of worsening or a non-response of the lesions, or in case of a moderate to severe skin eruption with an uncontrolled underlying disease from the start, switching to a different class entirely should be the adopted strategy. In our patient, we discontinued the anti-TNF agent infliximab, and we started him on a small dose of oral steroids, 30 milligrams, together with a topical steroid cream. And for control of the inflammatory bowel disease symptoms and the psoriatic lesions, we decided to give the patient a weekly subcutaneous methotrexate injection with folic acid supplements instead of the anti-TNF agent. After 4 weeks, a notable improvement of the skin lesions was seen. On the left, we have the pictures of the palm and the sole lesions before discontinuation of the anti-TNF lesions, anti-TNF agents, I'm sorry. And on the right, we have the lesions improving after 4 weeks of discontinuation and starting oral steroids and methotrexate. 6 months later, the patient had a full resolution of the lesions at subsequent follow-up, and he is currently in a clinical remission regarding his IBD symptoms on weekly methotrexate and steroids. The most two important take-home messages from this case is, first, Crohn's disease is considered a chronic inflammatory condition with numerous multi-system extraintestinal manifestations and associated conditions. This places particular emphasis on the importance of the multidisciplinary team approach. The second take-home message is that anti-TNF agents can paradoxically trigger psoriasis in a minority of patients, and this should in fact be kept in mind whenever a patient develops a newly developed skin lesions after beginning anti-TNF agent. Thank you.